Thank you, Dr. Gooding. If we could perhaps have the lights down somewhat again. And the first set of slides. It's somewhat daunting being mostly and primarily concerned with adult manifestations of pulmonary disease to be here this morning with the faculty present and talking about something that ordinarily one would not think of as a topic of interest to an adult pulmonary radiologist. If we could have this slide as well, please. My interest in this field has been spurred mostly over the last decade by the not infrequent finding of patients and cases who present in the adult age group with congenital disease. And so that was certainly one impetus for me to become interested in it. This is the, could you go back one on this, please? There's nothing before this. Should be one slide before this. It would be very unfortunate if that's not there. There's nothing before it. Could you advance these two for a second, please, then? Okay, so go back then, and we'll just take it from the beginning. There's a slide there that's missing, which is rather unfortunate because it's a fairly important one. If we could go back to the first set of slides. The other reason why I'm interested in this particular subset of disease is because there is perhaps, in my judgment, and at least in our experience, looking at the use of MR in particular, to a lesser degree CT, but certainly MR, few, if any, groups of diseases that lend themselves quite so well to evaluation by MR. And the rationale for that is has to do with the nature of the disease entities that actually fit into this description or under this category of congenital pulmonary disease. Now, by far, the most common way of organizing or thinking about this is to speak in terms of the sequestration spectrum. And people have pointed out that when we talk about sequestration or the sequestration spectrum, what we're talking about on one end are diseases in which there is abnormal pulmonary parenchyma, frequently associated with abnormal fluid collections, and on the other end of the spectrum, abnormalities of vascularity or abnormal vessels supplying otherwise normal parts or pieces of lung. And if you think about it, that spectrum does lend itself quite nicely to evaluation with MR, as I'll show you throughout the course of this lecture, since so many of these entities either associated with abnormal vessels or associated with abnormalities involving fluid collections. Those are two particular areas in which MR is particularly helpful and particularly accurate in delineating the extent of disease. Now, what constitutes this spectrum? Well, there are a number of disease entities, and we'll go through these sequentially. The first is the whole subgroup of congenital lobar emphysema. This describes one end of the spectrum in which we have abnormalities within the lung without an associated anomalous or abnormal vascularity. So what we see are over distension of one or more lobes. There's a diverse set of pathogenic mechanisms behind this, and there are all these different subtypes that have been described. In the adult population, the one that we see by far most frequently is bronchial atresia, which does constitute one particular subset of this group. And we can define bronchial atresia as focal obliteration of a segmental bronchus with normal remaining distal lung. This is presumably vascular etiology. What happens is you have a blind ending bronchus, typically to the left upper lobe, behind which the lung is normal, although it tends to be hyper-aerated. What we see on a chest X-ray, actually first defined or best defined by Dr. Felsen some time ago, is typical of mucoid impaction, especially in the left upper lobe, and associated with lobar emphysema. Okay? Now, when we see this, it's really quite characteristic. We see on a chest radiograph a mass that tends to be central, but in the left upper hilar region, or in the proximal portion of the left upper lobe, behind which we see a hyperaerated lung. Typically, this has a branching configuration, which I think we can see to much better advantage when we look in cross-section. And what we see are a typical appearance on CT of mucoid-impacted airways. One might anticipate seeing air within these, but typically we don't. And they branch, and they are associated with hyperaeration, and I'm not sure how well this projects, but if we look at the normal density of the right upper lobe and compare that to the left, you can see there is extensive hyperaeration within. Now, as I said before, MR is a particularly nice way to evaluate these patients because MR is best at detecting water and detecting abnormalities in blood flow. In this particular instance, we can say unequivocally this does not represent an abnormal vessel. This is a T1 and obviously a T2 weighted, heavily T2 weighted sequence. And you can see that on a T1 weighted sequence, we do see, again, the same anatomy of this branching structure in the left upper lobe. And when we look at this with a T2 weighted sequence, we can see a very characteristic appearance of mucoid impaction within the airways. And this is characteristics actually first defined on MR by Dr. Gooding when he was describing mucoid impaction in patients with cystic fibrosis. The appearance is absolutely the same in this subpopulation of patients with bronchial atresia. And we make an unequivocal MR diagnosis in this case. Now, also along the edge or along the side of the spectrum in which we have abnormalities within the parenchyma of the lung unassociated with anomalies or abnormalities of the vasculature are bronchogenic cysts. And bronchogenic cysts in themselves constitute an entire half an hour discussion. They're really a fascinating topic. What you see, or at least by definition what you'll find, are masses of non-functioning pulmonary tissue. They represent a developmental defect of mesenchymal cells growing about the lung bud. They're lined by columnar epithelium, and so they contain all the elements of the bronchial wall. That's particularly obvious, of course, to the pathologist, not so much to the radiologist, in differentiating these cysts from cysts that occur in other organs and in sites. The contents are very variable, and that's important in terms of our ability to recognize them rentgenographically. They range from very clear fluid to thick, very mucoid material, and as I'll show you, these can even be calcified. They're not asymptomatic all the time. They can be an incidental finding, but they can cause infection and they can bleed, and as I'll show you, they can be a cause of dyspnea. And because they can have bronchial communication, they can get infected, and so we can see them as containing air on a chest radiograph. Now, let me just back up for a second on that side. This was a young woman who presented. She was Korean, and her single biggest problem was that she wasn't running the mile as well as she used to. And I would submit to you this is a perfectly normal chest radiograph. But someone took her seriously, and so they performed a perfusion and a ventilation scan, and you can see quite obviously that there is a mismatch here in terms of the ventilation and perfusion to the left lung is considerably greater than it is to the right lung. And this prompted us to look again with MR, and this is a sequence of coronal images through the carina, and we can see that in the subcoronal space there's a well-defined mass that has an intermediate signal intensity on a T1 weighted sequence. And I show you here sequential axial images, and this is the way, just parenthetically, we perform most of our T2 weighted sequences, and it's worth spending a moment on. What we typically do, and this doesn't just pertain to congenital disease, but virtually any application of MR, we do a T1 weighted sequence to define the anatomy. And then at the point of interest, or at the section of interest, what we perform are single-level multi-echo sequences. And so this represents a 30, 60, 90, 120 millisecond echo. And in fact, we typically take it out much further than that, into the 200 range. And by doing that, you can see, giving us a very heavily T2-weighted sequence, that this mass that is subcoronal clearly is fluid-containing and is typical of a bronchogenic cyst. The reason why this particular patient had so much decrease in the perfusion and ventilation of the right lung is shown in the corresponding CT bolus study. We can see typical appearance of a non-enhancing mass, fluid-containing subcoronal, which is clearly compressing the right pulmonary artery just at its origin. Why was the MR signal intensity on the T1 weighted sequence intermediate? Well, because this is what this fluid looks like when it was in fact aspirated. This is not clear serous fluid, but in fact contains old clotted blood within. And that's an important realization. These particular lesions can have a wide variety of fluid contents, and the result, therefore, is they can have a wide variety of densities. This is a case that was run to me from the AFIP by Dr. MacArthur. You can see that there is here also a subcoronal mass, which has the same basic tissue attenuation as the remaining of the vessels, and you can see why this doesn't have a fluid density on a CT scan. because it's so mucoid, if you will, on a cut section. And in fact, just to go to the extreme, this is the densest bronchogenic cyst that we've ever had. I do believe the ceiling is falling in. You can see that there is obviously, again, a subcarinal lesion here. There's a fluid collection in the pleural space, but I draw your attention to the density here. This is entirely milk of calcium filled bronchogenic cyst. So be aware that on a routine CT study, these will have very variable densities. Why do these patients sometimes present symptomatic? Here's a patient who clearly has decreased perfusion throughout the left lung. There is a mass, which I think is best seen on the CT scan, and it has a fluid density, rather, just at about the point of the AP window. It's clearly compressing the trachea. And the end result of that is that the left mainstem bronchus is really quite narrowed. We see it just as a slit here. There is some inflation, but you can see it's much and markedly decreased. This is also compressing the esophagus. This patient also had dysphagia and, in fact, was aspirating, which is why we see all of these areas of airspace consolidation in the right lung. So it's apparent that these things are not as benign as they might seem, and depending on their size and location can be extremely problematic. Now, just a very brief word about what is in the adult population an exceedingly rare disease entity, and that's this phenomenon of congenital cystic adenomatoid malformation. Typically, this is a problem or pathology that's seen in the neonate and the young, not in the old. But we have recently had the experience of seeing several of these. Just by definition, they're multicystic masses. They're characterized by adenomatous proliferation of the terminal respiratory structures, and one can subdivide these into three types depending on the size and the number of the cysts. One sees, for example, here a mass in the right lower lobe. There's an air fluid level. One might wonder about some kind of infected cyst or perhaps even a sequestration, which is what our first thought was. But in fact, what we see are these multiseptated, thick-walled cystic masses. This is another patient who presented with the same. Both of these patients were over the age of 30, and at surgery, both of these represented a cystic adenomatoid malformation. At least you can say that you've seen two of them. Now, far more common and far more important, I think, in terms of our differential diagnostic skills is bronchopulmonary sequestration itself. And we define this as a cystic mass of non-functioning lung, but now we're starting to move pretty much square in the center of the spectrum of these findings. Abnormal non-functioning lung, in this case associated with anomalies of the blood supply. Typically they occur without bronchial communication. There is no one satisfactory embryologic hypothesis. I dare you to read all the literature that's been written concerning what does and does not constitute the embryology of this. It's really daunting. Most cases, frankly, are composite. While this definition certainly applies as a generic in terms of individual cases, as I'll show you, you have to be a little bit shy of assuming that in every case you're going to see every element of it. And so composite findings are particular. And in particular, what tends to be composite are the findings of intra and extralobar sequestrations, which in fact can be found together. Most frequently, we make this diagnosis in the second and third decades in patients who frankly are asymptomatic. Although very much like bronchogenic cysts, depending on their size and location, they can be a cause of infection and in fact may cause hemoptysis. Now, there's been a lot written, and I think it is probably valuable to try to differentiate between intra and extralobar sequestrations. I must tell you from this side it's difficult to read. I can tell you that an intralobar sequestration is within the lung, and extralobar sequestration has its own pleural investment. Typically, the arterial supply to an intralobar is from the aorta, and it usually is a large vessel as opposed to an extralobar sequestration. The venous drainage in an intralobar also tends to be within the lung to the pulmonary veins, whereas extralobars tend to be to systemic vessels such as the azygos and the hemiazygos. These tend to be far more common in the neonatal period, frankly, although we do see these in associations with intralobar sequestration in the adult population. And the one that is more typically associated with other congenital anomalies by far is the extralobar sequestration. I think it's valuable to have these differential points in your mind, but do be aware there's a considerable overlap. And what do we see? A patient who clearly has a density at the left lung base. This is abnormal. And I think, in general, if I told you this was an asymptomatic patient and this was your board exam, you might in fact think of intralobar pulmonary sequestration. What we see, at least from the CT scan point, is not totally different from what we'd expect to see in someone who has bronchial atresia. We see branching, dilated airways, mucus-filled, and the surrounding lung here is obviously hyperinflated. If we compare the density of this left lower lobe to the right lower lobe, clearly this is a hyperinflated lung. The difference between bronchial atresia, however, and the sequestration is shown here. This is a bolus study at the level of the base of the lung, and we can see the very characteristic features on CT of clearly dense opacification of the aorta, as well as this anomalous vessel which arises from the aorta. Note that the mucoid-impacted airways are fluid-filled, they're not vascular, and so in the phase of maximal arterial opacification, we see no evidence of enhancement whatsoever, and we make a definitive diagnosis here of an intralobar pulmonary sequestration. Similar findings on the MR. Not surprisingly, the fluid-filled bronchi will appear as branching areas of fluid, as shown here. And if we look carefully, we can identify the anomalous vessel arising here just above the diaphragm. You may not see very much more than this, frankly, because these vessels can be tortuous. They can go in and out of the plane. But if you recognize this much in association with the kind of mucoid-impacted airways I've shown you on MR, that is a definitive diagnosis. Now, I've shown you chest radiographs, I've shown you CTs, I've shown you MRs, I've shown you angiograms. I will tell you that increasingly we only do MR. This is a patient who presented, and our pediatric radiologist very astutely picked up there was a density at the left lung base. The next study was performed, I'm showing you now, which was the MR, and we make an unequivocal observation of an anomalous series of vessels arising from the descending aorta, supplying a clearly well-defined anomalous area of pulmonary parenchyma, well demarcated by the diaphragm inferiorly and by lungs superiorly. We can even see that there's abnormal drainage into a dilated hemiazygous vein. This patient does not require a CT. It does not require a sonography or a sonographic examination or an arteriogram. The patient went to surgery essentially based only on the MR appearance of this lesion. Now, I was in Sun Valley last week, and I showed this case and made the observation that in our institution now, if we suspect sequestration, we immediately go to MR. And he said, well, I had a case, this particular course participant, where it wasn't as easy as you're describing, Dr. Nadish. Why do we do the MR? We do the MR because I think the CT can be very difficult to interpret, and I made that point. I looked at the literature and kind of reviewed what had been reported previously, 14 cases. There have been more subsequent to the time I put this together. Not insignificantly, the diagnosis, which usually rests on the ability to see the feeding vessel, was actually only reported as being visualized in a minority of cases. And that was a lot of the logic of why I thought it was important to start using MR for this particular subset of patients. And so this is the case that he sent me. And I think you can see that there is a density at the left lung base here. And I'll show you the corresponding MR, and sure enough, there is a vessel. It clearly is arising from the distal aorta above the diaphragm, very much, if not exactly analogous to the image I showed you a second ago. And there are these bronchial-impacted airways in the left lower lobe that have fluid within. And so I said, well, this is a particularly easy case. I can't imagine why he had any difficulty at all. This is obviously an intralobar pulmonary sequestration. And how could you doubt that? And here are the dilated bronchi within. And what I walked right past was this finding of what is, in fact, an anomalous vessel to the right lower lobe, which, frankly, you can make out, although I think you'd have to be quite bright to pick up that this is an anomalous vessel on the CT that's not enhanced. I would draw your attention to how difficult, if not impossible, it is to identify this vessel on the right side. A simple spin echo images may, in fact, not be adequate to define anomalous vessels in this population of patients. Suffice it to say that the angiogram here was definitive. You can see there is, in fact, an anomalous vessel to the left lower lobe, but this is a selective injection into the obviously large vessel feeding the otherwise normal-appearing lung in the right lower lobe in this patient with bilateral sequestrations. So I still think that MR is the way to go to evaluate these patients, but I am a little gun-shy now about saying that simple spin echo technique is sufficient. And let me just show you another example of why I'm a little gun-shy of saying that for all of these lesions. Another subgroup in the population of congenital disease is the so-called hypogenic lung syndrome or scimitar syndrome. And these are characterized by anomalous venous return, right lung always, usually to the inferior vena cava, occasionally to the right atrium. You see the scimitar shadow. You can see one here on this chest radiograph. There's obviously hypoinflation of the lung in about a third of cases. There is association between this phenomena and anomalies of lobation. Typically, they'll have bilateral left lungs, also frequently associated with hyperplasia of the right pulmonary artery. Typically, these present without any kind of symptomatology. Now, we can make the diagnosis, I think, easily enough on a plain film. What we see on CT are anomalies of lobation. This represents really a left upper lobe bronchus on the right side. You can see there's hypoinflation of the lung and shift of the heart and mediastinum. And in fact, at the right lung base, we can see these large anomalous vessels, which we can track down into the inferior vena cava, and we make an unequivocal diagnosis of scimitar syndrome. And we can look at this with MR as well. Here you can see there's a hypoinflated or hypoplastic right lung. The pulmonary artery here is perfectly normal. Notice, however, as compared with the CT, how difficult it is on these routine spin echo images to see the anomalous vessels in the right lower lobe. Because these are anomalous vessels within the parenchyma of the lung, you have no signal and no signal, and so it can be very difficult to identify. You can, in fact, see that there is an anomalous vessel joining here the inferior vena cava, but I think you can see that there is a certain problem, at least in some of these cases, in identifying anomalous vessels if you only rely on a spin echo technique. Well, what about vessels? And let's spend one more second in terms of our spectrum. Now, we've worked our way from anomalies of the architecture of the lung unassociated with abnormalities or anomalies of vessels to the other end of the spectrum, where the lung is normal, but we have anomalies of the pulmonary vessels. And AVMs, I think, are a reasonable diagnostic dilemma for us. We think about them a lot. It's amazing how often both my residents and my peers will look at a radiograph and say, well, maybe that's an AVM. It's amazing how rare it really turns out to be. Nonetheless, most of them are congenital, persistent fetal capillaries usually being the explanation. The arterial supply is usually from the pulmonary artery. It's very rarely systemic. The venous drainage is to within the pulmonary veins. They tend to be near the visceral pleura. They can enlarge. There is obviously a known association with Osler-Weber-Rondeau. I could never say that 30 times. About 15%. Again, it typically presents in the third and fourth decades, not unlike sequestrations. They're frequently multiple, often bilateral. And there is a classic triad of symptoms that have been reported in association with these, including dyspnea, cyanosis, and clubbing, and the association of a right to left shunt, which can in fact lead to brain abscesses. Typical appearance here of a mass, and we can look at that on CT, and they're really very characteristic on CT. It's a kind of a simple diagnosis to make. They tend to be subpleural, and so we see a mass, and we can, frankly, in most cases, see the associated anomalous vessels. I don't think anyone would have any doubt looking at this lesion that they're looking at an AVM. These can be somewhat more subtle. I'll show you another example of a patient who had some densities at the left lung base. I think you can see there are a couple of large vessels that we can identify in the lateral radiograph, and perhaps you can suggest the diagnosis from this pair of images. If we look at sequential images now, you can see that on this image, I think it would be very difficult to identify any abnormality, but notice that these two vessels can be traced out into the periphery of the lung, and they maintain their size. So if you're going to look for anomalous vessels in the lung, you really do have to look at sequential images. You can see here that these are quite larger than anything in the corresponding middle lobe. And in fact, we can trace these again all the way to the periphery of the lung, and a bolus of contrast shows us quite clearly the presence of an AVM. Now, how do we get around the problem of looking at these vascular lesions in the lung? As I suggested already on spin echo images, this can be problematic, and I show you this is a different case, of an AVM in the periphery of the lung. And unless I was using this pointer to outline this lesion right here, I sincerely doubt any of us would actually identify that. Signal void in an AVM surrounded by the signal void of lung, as we've already suggested for sequestrations. And for scimitar can be a problem. The way to solve this is to use gradient refocused echoes. These are very sensitive to the presence of flowing blood, and what is a non-diagnostic image here becomes immediately diagnostic. You can see all this signal, bright signal, originating from this peripheral AVM. And I think this is an informative slide, therefore. If we're going to use MR to look at this group of lesions, we really should, in our routine evaluation, not only use spin echo images, but use gradient refocused echoes as well. Just to show you the angiogram, in this particular case, you can see there's obviously an AVM in the periphery of the lung. Now, so far I've presented all of this spectrum of findings as though each one of these is an identifiable and unequivocal separate phenomena in its own right that we can classify in every case. And that's clearly not the case. So let me just show you this one example to make the point. It's a patient who had a mass actually first picked up on sonography above the left kidney, which was clearly cystic. I'll show you that here with some thick wall around it. Was this an adrenal lesion? You can go through the differential in your own mind. You can see in this coronal MR that there is a mass on the T1 weighted sequence. It's got a low signal intensity. It is about where the adrenal would be. It's clearly separate from the kidney, separate from the spleen. Does this represent an extra lobar pulmonary sequestration? We really don't identify all that clearly anomalous vessels here. I show you the corresponding CT. There is an area of low density, again, subdiaphragmatic. And I'll show you the equivalent MR in the axial plane. You can see that there is a mass here which has very little signal on a T1 weighted sequence and has considerable signal on a T2 weighted sequence. But again, we were not able to identify the presence of anomalous vessels. As I've pointed out, I don't think using spin echo images by themselves is sufficient. Suffice it to say this patient went to surgery, and this in fact represented an extralobar pulmonary sequestration. But what was of interest to me in this particular case, and the reason I'm showing this to you, is that within this extralobar pulmonary sequestration, there were large areas with this morphology. And I appreciate that we're not pathologists, but this is typical findings in someone with congenital cyst adenomatoid malformation of the lung. And in fact, that's what this represented. This was an extralobar pulmonary sequestration within which there were large areas of congenital cyst adenomatoid malformation. And the point I want to leave you with is that while we talk about each of these individual entities as though they're separate and definable, the crossover between them is phenomenal. And it is not at all unlikely that you'll see elements of one of these types of lesions co-mixed or in fact present simultaneously with others. And so you have to be aware of this crossover phenomena. With the time left to me, there's one other entity. I don't know that it would necessarily be considered a typical entity that is discussed in this subgrouping of patients, but I show it to you anyway because we have seen one and I've become interested now. There have been others that have been reported in the literature. This is from 583. You can see that there is a mass in the right lower lobe. This is approximately 7 months later. You can see that this mass has grown, has a somewhat curvilinear configuration. Does this represent an AVM? What exactly does this represent? I show you the corresponding CT images. It's a subpleural lesion, but clearly we don't identify any anomalous vessels in association with this. We can say unequivocally this is not an AVM. There is some cavitation associated with this lesion, but I don't know if we can really characterize it any better than that. Does anyone have any ideas what this might represent? Well, we didn't have any better idea either, and so the patient went to surgery, and what this represents is a pulmonary blastoma. It doesn't quite fit the description of sequestration spectrum that I've shown you, but there are features that overlap, at least radiographically, which is why I've included it. These originate from pluripotential or mesenchymal cells. The counterpart, at least histologically, is a nephroblastoma. They are potentially malignant, so even if you don't recognize it pre-surgically, these do need to come out, and they can metastasize to regional nodes and, in fact, the brain. Macroscopically, like AVMs, but obviously different, they do lie beneath the pleural surface, but they tend to be sharply marginated. They can hemorrhage, and they can have necrosis, which is why they're cystic. And microscopically, they're undifferentiated embryonic connective tissue, much like a rhabdomyosarcoma. If I could have the lights, please. I think that's the last slide. What I've tried to do is to show you the spectrum of findings that we see of congenital disease within adults. Some of these are arcane, some of these are less common than others. But I suggest to you that you should be aware of them. They do pop up periodically. We can make very definitive diagnoses, and I think it's perhaps of all areas of chest imaging where MR, frankly, is of most help to us. Thank you very much.